Hello everyone. As we all know, cataract surgery in presence of corneal opacities is double the trouble. Difficult visibility of the underlying structures impedes all the maneuvers such as rhexis and the nuclear management. The stained anterior lens capsule provides a good contrast during the surgery through these whitish corneal scars. Hence the analogy, seeing blue moon through the white clouds fits best in this situation. In this video, we demonstrate various intraoperative challenges faced during cataract surgery in these cloudy corneas and their management. The standard of care in such patients will be to perform a penetrating keratoplasty and cataract surgery either in the same sitting or subsequently. But paucity of good quality donor corneas, high graft rejection rates, and poor compliance to medication and follow-up make penetrating keratoplasty often not possible. Therefore, cataract surgery alone can provide timely visual rehabilitation in such patients. Our first case is that of a 42-year-old welder who was treated for fungal keratitis and referred in 2022 to us for possible corneal transplant. As the scar was paracentral, we decided to do only a cataract surgery first, then assess the outcome and decide on possible corneal transplant later. Intraoperatively, the pupil was hardly dilating. Hence, we decided to mechanically dilate the pupil using iris hooks. As we see, the surgeon here engages the pupil using 4 iris hooks and tightens them. Synecholysis was performed, a good rhexis was done, followed by hydrodissection and phacoemulsification of the nucleus. Few of the iris hooks were then disengaged and removed. This was followed by cortical aspiration. But while aspirating the cortex, the surgeon accidentally pulls the bag, only to realize it later. Then proceeds with implanting a single-piece foldable IOL in the bag. But then realizes the IOL wasn't quite stable and that there is an inferior zonular dialysis. Decides to place a capsular tension ring to support the inferior zonular dialysis, but it wasn't going in the intended location. Hence, we decided to explant it. The IOL was prolapsed from the back and explanted. Did a thorough anterior vitrectomy and decided to place a retropupillary iris claw lens. The iris claw lens was then introduced into the anterior chamber and centered over the pupil, then enclaved posteriorly in the mid-peripheral stroma of the iris at around 7 o'clock and 2 o'clock away from the corneal scar. The IOL was well centered and stable. We sutured the corneal tunnel. The vision on post-operative day 1 was 2600, which improved to 2050 at post-operative 6 weeks. Our second case is that of a 74-year-old farmer who presented to us with complaints of diminution of vision in his left eye since 10 days. He gives a history of undergoing corneal transplant in right eye locally 45 years back and was deemed amblyopic in that eye. This was the slit lamp picture of the right eye, which showed clear corneal graft with posterior subcapsular cataract and an inferior iris coloboma. The slit lamp picture of the left eye shows a leukomatous scar with central thinning and lipid deposits in the periphery and iris coloboma, also noted to have an intumescent cataract. The vision was hand movements positive. Corneal sensations were absent in both the eyes. In view of the patient being one-eyed with poor corneal sensations, we planned a small incision cataract surgery with IOL and lateral paramedial torsography in that eye. Intraoperatively, side put was made and the anterior lens capsule was stained to enhance visualization during the rhexis. Synecholysis was done with an iris repositor to promote ease of subsequent maneuvering. Rhexis forceps was used to complete the rhexis. A sclerocorneal tunnel was made. A good hydrodissection was performed, followed by a smooth delivery of the nucleus through viscoexpression. With the anterior chamber maintainer in place, the remaining cortex was aspirated using a single port cannula. A 3-piece IOL was then implanted in the bag. The side ports were hydrated and followed by suturing of the tunnel. We then proceeded with the lateral paramedial torsography. Post-operatively, the vision improved to 20/100 and remained stable since then. This was another case of a 66-year-old female with bilateral corneal opacities. Right eye was exotropic with adherent glaucoma. Left eye had central leukomatous corneal opacity with significant cataract. We planned cataract surgery in the left eye in view of guarded visual prognosis in the right eye. Side ports were made, retroillumination was used. Anterior lens capsule was then stained. Rexis was initiated from a relatively clear corneal window and completed. Superior clear corneal incision was made and an entry into the anterior chamber was done. Thorough hydrodissection was done. Mobility of the nucleus checked and proceeded with phaco. As the nucleus appeared softer, we repeated hydrodelineation and prolapsed the nucleus into the anterior chamber. The nucleus was then phaco-aspirated. After uneventful phaco-emulsification, cortical wash was done. We used retroglow from the peripheral fundus to facilitate our cortical wash as the scar was central. Then a single piece IOL was implanted in the bag and dialed. This was followed by good visco wash. We did a peripheral iridectomy to promote peripheral vision as there was a central corneal scar. The side ports were then hydrated and eye closed. On post-operative day 1, the vision improved to 21-25 and was started on oral aciclovir 400 mg BD dose along with topical antibiotics, steroids and lubricants in view of bilateral corneal scars with reduced sensations. Some of the management strategies to perform a safe cataract surgery in these eyes include capsular staining with dye, synecholysis to improve pupillary dilatation, using either iris 6 or sphincterotomy to dilate the pupil, finding a clear corneal window to initiate rexis, using alternative sources of illumination such as endoscopy, retroillumination, or the transcorneal oblique illumination. Thank you for the opportunity given.